Hello again everyone. I am Dr. Tamoghna Jana from Department of Oral and Maxillofacial Surgery, Sri Balaji Dental College and Hospital, Chennai. Today we shall be discussing on a very important topic, that is midfacial fractures, which comprises of LeFort I, 2, 3 and NOE fractures, that is naso-orbitoethmoidal fracture. So coming to the basic anatomy, the middle third of the facial skeleton is an area bounded superiorly by the line drawn across the skull from the zygomatico-frontal suture of one side, across the frontonasal and frontomaxillary sutures in the zygomatico-frontal suture on the opposite side. Inferiorly by the occlusal plane of the upper teeth, or if patient is edentulous, by the upper alveolar ridge. Posteriorly, the region is demarcated by the sphenoethmoidal junction, but includes the free margin of the pterygoid laminae of the sphenoid bone inferiorly. Here you can see a diagrammatic or pictorial representation of the bones comprising of the midfacial bones. We can see the zygomatic bone, the palatine bone, the vomer, the inferior nasal concha, the lacrimal bone, and the nasal bone. Now supply. The middle side of the face is supplied with the second division of the trigeminal nerve, also known as the maxillary nerve, and the regions above are supplied by the ophthalmic nerve. This is the first division of the trigeminal nerve. Branches of the maxillary nerve are infraorbital, superior alveolar, greater and lesser palatine, nasopalatine, zygomatic nerve, middle laryngeal, supralabial, pharyngeal, inferior palpebral. Blood supply. The facial region is supplied by the branches of the external carotid artery. The third part of the maxillary artery, its terminal branches are closely associated with the branches of the middle side of the face. Occasionally, the artery of or its greater palatine branch is torn in the region of the pterygomaxillary fissure or pterygopalatine canal, resulting in severe life-threatening hemorrhage into the nasopharynx. Facial vertices. The central midface has many fragile bones that could easily be crushed when subject to strong forces. Thus, they are surrounded by a thicker bone of facial buttress system, lending it some strength and stability. These are generally made out of cortical bone. Midface buttresses are composed of frontal bone, maxillary bones, zygomatic bones, sphenoid bones. Components of buttress systems are vertical buttress and horizontal buttresses. As you can see in the diagram, the horizontal and the vertical buttresses of the midfacial regions. Vertical buttresses are nasomaxillary, zygomatic-maxillary, pterygomaxillary, vertical and they all resist the occlusal root. Horizontal buttresses are frontal bar, infraorbital rim, nasal bones, hard palate, and maxillary alveolus. They interconnect and provide support for the vertical buttress. The naso-orbitoethmoidal region is situated in the central upper midface and consists of a strong triangular frame. The five cavities that are involved in the NOE region are the cranial cavity, the orbital cavity, nasal cavity, maxillary sinus, ethmoidal air cells. The orbit, in this picture we can see the bones which comprise of the orbit, the lesser wing of sphenoid. The superior orbital fissure is just in the between the greater wing of sphenoid and the lesser wing of sphenoid. There is the frontal bone superiorly, which also just below it there is the optic canal. Ethmoidal foramina is also there. Ethmoidal bone, lacrimal bone, palatine bone in the middle portion, zygomatic bone laterally, and maxillary bone in the inferior region. Fracture of middle third. Types of midfacial fractures are LeFort I, 2, 3, zygomatic complex fractures, zygomatic arch fractures, orbital blowout fractures, nasal fractures, NOE, that is the naso-orbitoethmoid fractures. These may be isolated or may occur in combination. Classification. Eric's classification, according to the direction of the fracture line, gave as 1. Horizontal fracture, 2. Pyramidal fracture, and 3. Transverse fracture. LeFort classification comes as LeFort I, 2, 3, and 4. The fourth variant was recently added. It comprises of orbital fractures as well, superior orbital fractures. Another classification based on relationship of the fracture line to zygomatic bone is subzygomatic and suprazygomatic. And there is another classification depending on the level of fracture line: low level fracture, mid level fracture, and high level fracture. Coming to LeFort I fracture, This is from a horizontal force delivered above the level of the teeth to the maxilla. The fracture forces from the lateral border of the piriform aperture above the canine eminence, lateral antral wall, then goes behind the maxillary tuberosity across the lower third of the conjugal plate. Almost always involves the jagged process of the sphenoid bone. The fracture separates the maxilla from the jagged plates and nasal and zygomatic structures. This type of trauma may separate the maxilla in one piece or from other structures, split the palate or fragment the maxilla. May involve the maxillary sinuses. The resultant floating component is the lower part of the maxilla and its teeth. The nasal septum may be fractured also. The LeFort I fracture may be unilateral or bilateral. It may occur on its own or in combination with other facial fractures. As you can see, the diametric representation of a LeFort I fracture. Clinical findings of LeFort I: extraorally swelling of the upper lip, soft tissue laceration, open mouth to accommodate the displacement dental portion, epistaxis intraorally, malocclusion, mobility of tooth bearing portion, dull sound for on percussion, ecchymosis of the maxillary buccal sulcus. LeFort II fractures: the result from a force delivered at a level of the nasal bones in superior direction. The fracture line occurs along the nasofrontal suture, lacrimal bone, then goes to lacrimal bone, then goes to across the infraorbital rim in the region of the zygomatic maxillary suture, proceeds to above the canine eminence, then it proceeds inferiorly and distally along the lateral antral wall, but at a higher level than the LeFort I type. Then proceeds across the jagged plate at this middle portion. Separation of the maxilla and the attached nasal complex from the orbital and zygomatic structure. This is also known as a pyramidal fracture. Clinical findings of LeFort II is extraorally ballooning of face, lengthening of the face, circumorbital ecchymosis, subconjunctival hemorrhage, epistaxis, diplopia, inophthalmos, CSF rhinodia, step deformity in the lower part of the orbit, intact zygomatic bone and arch. Intraorally, malocclusion can happen, gagging of the posterior teeth and anterior open bite can happen, mobility of the maxilla, ecchymosis of the sulcus. LeFort III fractures result from when horizontal forces are applied at a level superior enough at orbital level to separate the naso-orbital epimetal complex, the zygoma and the maxilla from the cranial base. This is also known as craniofacial separation and disjunction. The fracture lines courses through the zygomatico-temporal, the zygomatico-frontal sutures, lateral orbital wall, inferior orbital fissure, medially to the nasofrontal suture. Fractures then fractures the pterygoid plate at the base. Most severe of the LeFort fractures, often associated with extreme soft tissue injury, large force is needed to cause this type of fracture. The resultant floating component is almost the entire face. Clinical findings of LeFort III: extraordinarily severe edema of the face, ballooning, lengthening of the face, flattening of the cheek, circumorbital ecchymosis, conjunctival hemorrhage, epistaxis, inophthalmos, CSF rhinodia, bilateral circumorbital ecchymosis, panda facies or raccooneyes, bilateral conjunctival ecchymosis, diplopia due to edema and hematoma, restrictive motility disorder can be mechanical, cranial nerve injury can be neurogenic. Intraorally, gagging of the posterior teeth and the anterior open bite, ecchymosis and hemorrhage of the buccal sulcus, mobility of the maxilla, mandibular influences. As you can see, this is the photos of clinical representation. In the left, you can see raccoon eyes or panda faces with bilateral ecchymosis, periorbital ecchymosis, and in the right side, you can see diplopia due to maybe muscle entrapment. Come to NOE fractures. The nasal bones and underlying cartilage are susceptible to fractures because of the nose maintaining a prominent position and central location of the face, and because it has a low breaking strength. Patterns of fractures are known to vary with momentum of the striking object and the density of the underlying bone. It was given by Murray 1994. As with other facial bones, younger patients tend to have a larger nasoseptal fracture segment, whereas older patients are more likely present with the more common fracture patterns. Classification. According to Alice classification, first type 1 en bloc with minimum displacement, type 2 en bloc displaced fracture with a large pneumatized sinus and minimum fragmentation, type 3 comminuted fracture with intact medial canthal ligament attachment to large bone, type 4 comminuted fracture with free medial canthal ligament attachment to bone not large enough for plating, type 5 gross communication needing of grafts. The second classification given by Rowe and Williams can be 1. Isolated NOE and frontal region fracture without other midfacial fractures. It can be unilateral or bilateral, and B, it can be isolated NOE and frontal region fracture with other midface fractures. It can be unilateral and bilateral. Coming to type 1, in the simplest form, NOE fractures are isolated involving only the portion of the medial orbital rim that contains a medial canthal tendon. Type 1 pattern consists of a single central ligament bearing the medial canthus. These fractures may be bilateral, complete, or displaced. Uncommonly, the medial canthal tendon is torn or avulsed completely from the intact medial bony wall. Type 2. Type 2 fractures are complete and may be unilateral or bilateral. They may be single segment or comminuted external to the medial canthal insertion in the central segment. Medial canthal ligament maintains continuity with the large fracture segment of bone, which may be used in the surgical reduction, as you can see in the photo. Type 3. Communication with the central fragment allows a fracture to extend beneath the canthal insertion, characterizing the type 3 fracture pattern. The canthus is rarely avulsed, but it has too many bone fragments that are too small to utilize for reconstruction. Pathophysiology. There can be violation of the primary buttress of the NOE complex, then combination of the entire complex may occur. Telecanthus, enophthalmos, and diplopia midface retrusion can happen. Clinical signs and symptoms of midfacial fractures. Gross facial edema may first show in the early stages of fracture, which will lead to distortion of soft tissue landmarks, laceration of nose and forehead, intracranial involvement, eye, forehead and nose pain, forehead paresthesia, traumatic hypertelorism, mongoloid slant, and subconjunctival ecchymosis. Associated ocular injuries can be enophthalmos, diplopia, entrapment of muscles, vertical dystopia, loss of lobe integrity, traumatic telecanthus, circumorbital edema, and ecchymosis. Subconjunctival hemorrhage, possible supraorbital and subtrochlear nerve paresthesia. Medial canthal tendon displacement. The medial in the first picture you can see the normal anatomical position of the medial canthal ligament. The medial canthal ligament is a crucial soft tissue component of the NOE complex. It arises from the anterior and posterior lacrimal crest in the frontal process of the maxilla. Traumatic telecanthus, the intercanthal to interpupillary ratio can become greater than half. Lack of eyelid tension, positive bowstring test can be done. Rounding of the medial canthus ligament can be seen. Shortening of palpebral fissure can be seen. Here you can see the measurement of the ratio for the intercanthal to interpupillary distance. Initial management, like any other trauma cases, the initial management is always the same for midfacial fractures. That's ABCDE. Airway blockage and also eliminating cervical spine injury. Airway blockage, the clinician or the doctor or the emergency surgeon should always see if the airway is getting blocked by any kind of foreign debris, blood, vomit, or fracture segments. Especially in midfacial fracture, because the entire midfacial skeleton can tend to be displaced inferiorly and block the entire airway. Cervical spine injury must be eliminated to prevent complete lower half permanent paralysis. Head block should be used to stabilize the head, and one X-ray should be taken for the cervical spine to ensure that there is no fracture and engagement of the spinal cord. B. Breathing. Tension, pneumothorax, pulmonary edema, and bronchospasm are the most common things that can happen in trauma case. We should always see. Also, we should look for paradoxical breathing or abdominal breathing or pain while breathing. C. Circulation. We should always we should eliminate the possibility of shock, which can be hypovolemic, obstructive, disruptive, or cardiogenic. We should always go for proper homeostasis and hemostasis to prevent major hemorrhage and loss of blood. D for disability. It can be seizure, hypoglycemia, meningitis, intracranial hemorrhage, or infarction or intoxication. This can severely compromise the management and prognosis of the case and increase the morbidity. E for exposure, hypothermia and hyperthermia, critical skin conditions such as fasciitis or urticaria are also major factors. Coming to examination, digital palpation and visual inspection is of paramount importance, which can be then augmented with radiographic investigations. Radiographic investigations like X-ray, PNS view, lateral view, Waters view, CT facial bones with reconstruction are the most important ones which we can use. To the left side, you can see the Waters view, where excellent view of maxilla, maxillary sinuses, zygoma, zygomatic arches, rim of orbit, especially floor and nasal bones can be seen. To the right is a 3D reconstruction which is showing midfacial fractures of, including the NOE complex, the orbital inferior orbital rim, and there is a LeFort I fracture as well, which can combine be told as a LeFort II fracture, along with a mandible fracture as well. Here we can see a transverse section of the CT showing nasal complex fracture, and another one showing SBDCH reconstruction of the midfacial fracture with cross combination of the bone. Examination of facial lacerations under sterile conditions to assess the depth of penetration of intracranial violations. Evaluate the degree of nasal or midfacial retrusion and intercanthal distance of greater than 35 mm is suggestive of trauma telecanthus, and measurement approaching 40 mm are almost diagnostic. Here you can see in the left hand side a supraorbital laceration which needs to be cleaned and closed. Then midfacial retrusion can be seen in the middle one, and the telecanthus can be seen in the last photo. Examination of nasal cavity for presence of CSF is very important, because in most of the midfacial fractures except for the LeFort I, CSF rhinorrhea is a very common clinical sign and symptom. The query for all patients is about the presence of watery rhinorrhea or salty post-nasal drainage. Test for bloody fluid that is suspicious of CSF rhinorrhea can be taken with a blotting test. The following diagnostic procedures can be performed if there is a suspected CSF leak. Clinical signs can be straw colored or clear nasal drainage. We can do a kill test with positive halo sign as illustrated in the photo. Comparison of the concentration of glucose between fluid and patient's serum can also be done. Also, beta-2 transferrin is a definitive test for CSF rhinorrhea. We collect 1 ml of suspected fluid in a red top tube, and then we send for biochemical analysis. This is a till test where the patient's fluid is put in a handkerchief or blotting paper, and in the central portion the blood will clot, and there will be a halo formation peripheral to it. The halo is a positive sign for CSF rhinorrhea. If blood is not there, the blotting test can also show a halo around clear fluid as well. Coming to Jones test, this is to investigate the lacrimal outflow under normal physiological conditions, and if the lacrimal pumping mechanism is compromised or not due to trauma. 1 drop of 2% fluorescein dye is placed in the conjunctival sac. After about 5 minutes, cotton tipped. This is Jones 1 test. After 5 minutes, cotton tipped applicator is inserted under the inferior turbinate. If bud stained with dye test is positive, test is negative, then no dye. When no dye is detected, that means there is a partial or absolute obstruction or failure of the lacrimal pump. Then we can also go to Jones 2 test, where clear saline irrigated through cannula inserted into the IMF cannulicus. Patient bends forward. Number 1, if nothing from a nostril, then complete obstruction distal to tip. If number 2, if fluid regurgitates, upper punctum is then there, patency of both canaliculi till the internal canaliculus. If clear fluid from nose, dye not entered canaliculi, blocked punctum or canaliculi, stained fluid, then positive test. That is normal. Treatment for fluid facial fractures. Definitive treatment, reduction in immobilization achieved by either conservative or operative methods. The sooner the treatment is carried out, the better the prognosis. Restoration of occlusion is a must. Bony framework and buttress of the midface must be repositioned or restored and fixed. Methods for reduction of the LeFort fractures: manual reduction, simple manipulation by hand, dental compound impression tray, gauze or rubber catheter, special instruments. Reduction by fraction can also be done, which can conservative treatment, supervised spontaneous healing, or open reduction. Coming to manual reduction, carried out in fresh fractures where fragments are not impacted. As a rule, arch bar can first be applied to the teeth. The lower jaw serves as a template so that the occlusion can be checked. Simple manipulation by hand is possible in fresh fractures. Pencil is held between the index fracture and thumb and brought to normal occlusion. Another method is to fix two double wire encircling the first and second maxillary molars and twisting them individually on each side, and then bringing the fracture segment into proper position. But if the lower jaw is also fractured and there is gross loss of occlusion, then this method cannot be used. Dental compound loaded into impression tray. It was suggested by Dingman and Harding in 1951 for mobilizing the fracture segment in maxilla. This can be used when some amount of fibrosis has set in because of the delayed treatment. When the impression compound sets, then the firm grip can be taken on the maxillary arch and the handle of the tray is used for rocking the maxilla into place. Ribbon strip gauze or rubber catheters can be used. Popescu and Burlibasa in 1966 have described the reduction by Robert dam sheaths or by means of long ribbon strips, gauze or rubber catheters. Whenever the maxilla is impacted and simple manual mobilization is not possible, then this method can be tried if sophisticated instruments are not available. Rubber catheters end is passed from the nostril into the oropharynx and it is grasped with the help of the hemostat and brought out of the oral cavity. So you can have one end coming out of the nostril and the other to the oral cavity. Same procedure repeated in the other side through the nostril. After grasping all four ends of the catheter and stabilizing the head, maxilla can be dropped into normal occlusion. Reduction by using special instruments. Rose maxillary disinfection forceps available as right and left forceps, always used in pairs. These are two-pronged divided forceps where one prong fits in the nasal floor and the other one into the hard palate. As you can see in a pictorial depiction, how the rose maxillary disinfection forceps is used. In the right hand side photo, we can see rose maxillary disinfection forceps being used in conjunction to a Hayden-Williams. Anti-reduction in case of split palate can be facilitated by the use of a special forceps device by Hayden-Williams applied to buccal aspect of the alveolar process and medial compression exerted until the two halves of the upper jaw are approximated. Reduction by traction. Deposition of the fractures that are already in a state of partial fusion or attempted manual reduction is made with failure. Then reduction by elastic traction is tried to integrate the fractured segments. Mainly used in delayed cases where the fracture is 10 to 14 days old and no longer sufficiently mobile. Intraoral elastic traction. Intraoral elastic traction with appropriate extension bars and side bars are used. Conservative treatment, reduction and fixation of the fracture segment is indicated in cases where surgery is not possible due to poor general conditions of the patient or where there is extensive combination of the with tissue loss, making internal skeletal fixation impossible. Also used in supplementary measure with surgical treatment of the midfacial fractures. Supervised spontaneous healing, where mobility of the fracture maxilla is only slight and occlusion is not disturbed. Process of healing is merely supervised. The patient should be avoiding chewing during the first 2 to 3 weeks and should take a liquid or semi-solid diet. Monomaxillary fixation. This method used when tooth-bearing section of the maxilla is not fractured and therefore can be served as a fixation point. The arch bar or palatal acrylic plates can be used. This can be used for unilateral fractures of maxilla or higher fractures without occlusal discrepancies. Maintained for 6 weeks. Intermaxillary fixation or maxillomandibular fixation as known now. Maintained for 3 weeks and at the end of this period the wires and the lower arch bars are removed. Internal skeletal wire suspension. Many times in addition to MMF, additional support is required for immobilization of the jaws. Craniomaxillary craniomandibular suspension can be carried out with the stable point above the fracture line. Procedure for internal skeletal wire suspension is just through minor surgery. An application of arch bar is done. Reduction of fracture by closed method. Occlusal instinct fixed to the fixation of the midface to the base of the skull by means of suspension wires. Fixation of the midface by tightening of the suspensory wires and maxillary fixation. For lingual patients, available processes or gunning splint can be used. This is a pictorial representation of how the suspension wires are put. The frontal bones are in the right hand side. You can see the frontal bone suspension, biform rim wiring, circumzygomatic suspension, circumzygomatic. The most commonly used is circumzygomatic or the frontal bone suspension. Coming to open reduction, carried out under endotracheal anesthesia and nasal intubation, intraoral vesicular vestibular incision is taken from the first molar to the second molar region or on either side, first molar to first molar region of either side. Uh, Mucophacial flap is reflected to expose the fracture line. After identifying the fracture line, in old fractures, an osteotome is inserted to mobilize the fragment. This impaction process can be used, and the fragment is brought to normal occlusion by manipulation. Temporary IMF is carried out, and fracture segments are fixed under direct vision by intraosseous wiring or mini bone plates with screws. For extensive high-level fractures of the midface, bicorner incision can be taken. This picture shows the mini plates or bone plates that are used for the fixation of the midface fractures, and its size is compared to a point. The plates generally are made up of titanium, but stainless steel plates can also be used. Orbital wall reconstruction. Bone material of choice for reconstruction is calvarial graft or rib graft. Long piece of bone used should extend just behind the medial orbital rim. Fixed with lag screws or mini plates can also be done. The bone pieces tend to be too posterior for poor access. A loss of stability can be there, and at that time, titanium mesh can also be used. The various skeletal incisions for exposure of the skeletal fractures are as follows: the supraorbital eyebrows incision, the subciliary incision, the median lower eyelid incision, infraorbital incision, transconjunctival incision, zygomatic arch incision, transverse nasal incision, vertical nasal incision, medial orbital incision. These are all extraoral approaches. For intraoral approaches, only the periosteal incision in the or the vestibular incision is used. Complications of plating can be misapplied fixation, infection can happen in the plate, nerve damage can happen, gingival and periodontal complications, malunion can be seen, delayed union or non-union, and inadequate immobilization and fracture alignment can happen, interposition of soft tissues or foreign bodies can happen, which will not enable primary healing, incorrect technique, and scar formation. Conclusion: midfacial injuries can be difficult to manage. Proper assessment and early surgical management of the midfacial and concomitant injuries are the key to optimal outcomes. Overcorrection of the bony position and compensation of the soft tissue overlying the medial canthal ligament are critical. Thank you. I hope you have learned a certain bit about the midfacial fractures and its management. Have a nice